paradigmei? Aflăm acum de la domnul Yiannis, Sotiralis, fizioterapeut din Grecia, formator clinic OMT, clinician acreditat în diagnoza și terapia mecanică, specialist în metoda McKenzie.
So, greetings, and I would like to thank the organized committee for having me discuss about this topic. And we are very fast because I know that this kind of conference has a lot of work that they have to fulfill. Let me start by saying that the topic that we are going to discuss today, it has to do with neuroscience implications in musculoskeletal physiotherapy. If we have, and if this kind of implication exists, and what kind of implications we have, and we can use them improving our everyday practice or not. So the objectives of today's presentation should be to understand what it is when we use the word neuroscience, what it really means, what kind of information we are having from this research field, how and which way it can be related to musculoskeletal physiotherapy, what kind of information we're having from the research, is there a need for a paradigm shift to the ways that we are approaching, the ways that we are assessing our patients? Do we have to change some things in our everyday clinical practice? And what are the next steps to the research of this field? So, a lot of you maybe have heard the words neuroscience or neurobiology, and if there is a difference to this to these terms. So, let's say that neurobiology is concerned with uncovering the biological mechanisms by which nervous system mediate behavior, function, etc. And over the past century, much of neurobiology has focused on the cells of the nervous system, the structure, the physiology of the nerve cells, and the supporting glial cells also. We could say that neuroscientists have a wider scope of field, and they study the cellular, the functional, the evolutionary, the computational, the molecular, cellular, and other medical aspects of the nervous system. More or less, I would argue that these terms practically are interconnected, and at this moment, it's practically the same thing. You all know, or I hope that the majority of you will already know, that we in physical therapy are dealing with the fall of the biomechanical structural model in all of the manual and physical therapy practices. And this means that the relationship between the origin of a problem, it's not so well supported that we have to be sure that this kind of tissue provokes this kind of problem and this kind of pain. As stated by Apkarian and Robinson from 2009, traditionally, all the diagnosis and the treatment problems that leading to chronic pain has been based on an approach called the end organ dysfunction. This means that something is happening, like a dysfunction or a degeneration on a tissue, that this provokes pain and restriction to the patients. And this led us to have approaches to try to help our patients by the means of something was need to be strengthened, something was in need to be stretched or to immobilized, or if we are talking also about medical approaches, to denervate or to remove, and etc., and stuff like that. However, now we know that these practices are not enough, and definitely they are not having the same effects, and especially if we are talking about population of patients that they are dealing with chronic pain situations. And this practically leave us physical therapists, but also medicine, with the big question mark. So how do we work? What do we do from this direction and above? The majority of our clients coming to us because they have two major complaints. They have pain, restriction, or a combination of both of them. So it's more than mandatory to know what is the pure dimensions of pain. What is pain? Are there any pain receptors, as we learned in the previous years? Is this structure or is this modality really exist? We all have been taught from the past that considering pain, Cartesian model was there to justify the pain experience. So there was a noxious stimuli like a fire, for example, and this could provoke pain. And you can see that this is a dual, a linear relationship between a cause and an effect. But in reality, we do learn now that this is not the case. So there is no linear effect of what is a cause and what is an effect. Pain experience is much more multifactorial and much more complicated than the simple explanation of the Cartesian model. So it's a good idea, the majority of us, to start to have the same definitions, the same terminology about pain and pain science. So it is well known at this moment that pain is an unpleasant, complex phenomenon consisting of sensory experience that include concepts such as time, space, tension, emotion, cognition, and also motivation. International Association for the Study of Pain, which has also this year changed the term that clarifies of what pain is, defines pain as an unpleasant sensory and emotional experience associated with or resembling that association with actual or potential tissue damage. And this is expanded upon by an addition of the 6 keynotes and the etymology of the word pain for further valuable context. This is made this way to help us clinicians to be able to understand the multi-directions and the multidimensional meaning of pain experience. Because of this, pain is subjective, so it remains to be an unpleasant phenomenon, but because its uniqueness for each subject, this means that it cannot be defined or measured by external observer. We cannot decide if our patient have a lot of less pain. We have to accept and believe what the patient describes as his pain. It's severe, it's less, it's more, it's medium. We have to accept how he feels his experience. It's his experience. The 6 keynotes from International Association of Pain that are there to help us as clinicians to understand the pain reality of the patient are like this, that pain is always a personal experience that is influenced to varying degrees by biological, psychological, and social factors also. This is the biopsychosocial approach. Pain and nociception are not the same, and pain cannot be inferred solely from activity in the sensory neurons as it was in the Cartesian model. We will see that pain can be provoked from other routes also. Through their life experiences, individuals learn the concept of pain in different cultural frames, in different contexts and beliefs. And also, we have to remember that although pain usually serves an adaptive role, it may have adverse effects on function and social and psychological well-being. Also, another point that has been described by the committee is that the verbal description of pain, it's only one of several behaviors that a person could experience pain. So inability to describe or to talk is not equal with the absence of pain. You can see in this schema that pain is based on through basic systems. From the one point you have the anterolateral system, which is the system that mediates information from the periphery to the central nervous system and to specific areas of the brain as the somatosensory cortex, which is the area of the brain responsible for interpretation of signaling coming from the mechanoreceptors, chemoreceptors, temperature receptors of the periphery. We also have the affective motivational component of pain, which is in all of these parts of the brain and represents the emotional response, the motivational response to the pain experience of the specific patient. And also we have the cognitive evaluating system, which is based mostly in our frontal and prefrontal cortex of the brain. Have in mind that in addition to sensory function, pain has also an emotional dimension and is without the component of pain memory, it was not so easy for us to learn through pain to avoid dangerous situations. You can see also in this illustration here what different areas of the brain are illustrating in different situations. When we are experiencing a negative effect, that you see that you have activation of the limbic system, but also from areas in the prefrontal cortex, or when you experience the pain in the limbic area and near the cingulate cortex, and what it means when in fMRI you see cognitive control, where you expect more activation in the frontal and prefrontal area of your brain. So, the majority of you will have at some point see this kind of illustration and representation of the roots of the nociceptive pathways. Generally, you could see him in books or in web resources, and they should be named as pain pathways in the past, but now we know this is not an accurate terminology. The accurate terminology should be nociceptive pathways, because as we're going to see, pain is not there by definition. So these are the pathways that they deliver messages that could interpret it finally and be perceived as pain, but this is not also a linear relationship. Nociception as a function has 4 basic stages. The first is the transduction of the signal, which means that the mechanical, the chemical, or any other activation that take place on the receptors, it has to be transformed in an electrical signal. This signal, it should be transmitted through the neural pathways, through the spinal cord to the specific areas of the brain that should be interpreted. And these paths are having different places that this signal could be modulated, and finally to reach the specific brain area, and that should be interpreted. If it was a visionary coding signal, then you are going to be able to see. If it was an auditory signal, you will be able to hear, etc., etc. If it was a sensory signal, you will be able to feel a specific sensation or pain, if this is the case. So it's a good idea for everybody to start to think that we are not having a thing like pain receptors. We have something like danger receptors, and this coding may be in a given situation be interpreted as pain experience. So the receptors that can code the stimuli that may be interpreted as pain, we call them nociceptors. And we have also two basic situations that could take place in an pain experience or in an injury, if you want. And we have the peripheral sensitization and the central sensitization that we'll talk about them in a minute. So peripheral sensitization, it takes place only in the place of the injury. When you have a tissue injury, then some kind of inflammation will take place, and this is going to create a sensitizing soup, if you want, in the area. And this kind of sensitizing soup, it will interfere and it will activate the sympathetic terminal, so the autoimmune system also would be activated. And all of this will make the receptors of the periphery more prone to produce more signaling that will finally go to the upper levels of the brain and may be interpreted as pain. To this schema, you will see what in the first line, what is the normal thing in the blue dot that you see Here, these are the receptors on the periphery, and in a normal situation, when there is no stimulation, as you can see, there is no pain sensation. In the cases of the peripheral sensitization, when you have a small stimulation or no stimulation at all, then some of the receptors of the periphery, they're starting to activate. And you can have, even with no specific stimulation, an amount of mild pain sensation. And when you have a peripheral sensitization with a mild stimulation, then you can have severe pain sensation in this case. And this is something that you can easily understand when you have like a strain or a sprain in your ankle and you have some bruising, some inflammation, and a small movement could provoke a very big amount of pain, even if it's not necessarily dangerous at this point for you, for a more extreme injury. Central sensitization, it's another procedure that takes place in the dorsal horn neural cells. There is a sequence of events that lead also in phenotype changes in the cells of the dorsal horn, and practically this means that these cells are becoming better to produce nociceptive signaling even in the absence of the signaling of the periphery. So the nerve cells in the dorsal horn can produce nociceptive stimuli even if they don't been irritated from signaling from the periphery. And this explains a lot of the majority of the time why do we have patients, chronic pain patients or long-lasting pain patients, that the tissues are now practically healed and we cannot find the tissue injury, but the pain remains. To all this, we have also to discuss a little bit about the two basic molecular mechanisms of the central nervous system about making memories and also enhancing the synapse. We have to discuss about these mechanisms, one of them called long-term potentiation, so it's LTP, and the other one is long-term depression, it's LDD. This, you can see that these are a complex molecular sequence of events that practically, to the one part, it's the way that our brain learns new things and get new skills, and from the other point, the long-term depression is the way that the synapse become weaker and we lose specific skills or we forget things. Imagine that these situations play a role then especially when you have a maladaptive behavior of pain experience, and especially pain that lasts a long through time. When you are exposed to painful situation for a long enough time, then the percentage, the possibility of dealing with chronic pain situations are becoming greater. Engaging ourselves in the study of the neuroscience data that can have some kind of implications for physical therapy profession, we're going to see words like neuroplasticity, which represents the ability of the nervous system to adapt in a new given situation. We can see the terminology of the cortical representations, which means that these are a number of neurons that working together and firing together and can represent words, thoughts, immune responses, a motor pattern, and a lot of other functions. And you can also see neurotags. We are talking about the combination of neural circuits working together again for specific functions. In patients that they're dealing with chronic pain, the representation in the primary somatosensory cortex, which is the area that accepts the sensory information, in the specific area of the lumbar spine, this area has been moved and extended to the area of the representation that usually we see the legs. This extension also is significantly related to the chronicity of pain. So the more the chronicity of pain, the bigger the extension and the altered representation of the lumbar spine. I think also the majority of you would have seen this picture. It's like the homunculus picture, and we all thinking that the brain should be something like that, that we have an area big about our hand, smaller about our trunk, etc., etc. But in reality, we know that this is not the case. It's a common misunderstanding that this is not a completely separated in terms of operation. It's not a muscle map, definitely. There are wide areas, functions that present or have the potential to overlap each other. And as declared by the researchers in this paper, the proper term to describe it maybe it should be like a map of statistical correlations in the behavior repertoire rather than a map of body parts. And as you can see here, the blue area in the brain represents neurons in the cortex that represent the wrist. And you can see that there is no well-orientated area. Or the fingers are with the orange and the lips are with the yellow colors. And you see again that there is no completely orientated area. You will see that this kind of information, they are starting to go deep to research and considering also sports, science, physical therapy, and we try to see what kind of information we can get from this and to adapt this in our everyday clinical practice. And we were going to succeed this if we are stop thinking only linearly. If we are stop thinking that every pain of our patient has to be related to one structure only. And so if I cure or if I improve the function of this structure, everything is going to be okay. No, pain is multifactorial, and now we have to think in a more wide way to try to interpret it. You see, for example, that if someone has a specific feeling or a specific belief, or he wants to perform a specific movement, all of this is related to primary and secondary neurotags. So with primary and secondary context that this person is having about the specific function or feeling. And this practically depends of what kind of lens do we use to see this approach for the patient or for the patient's pain practically. So you see that if you have pain from the one part, movement from the other part, these are representing two basic neurotags, one from the pain primary neurotag and one from the for the movement primary neurotag. So if you have a danger sign, so a nociceptive sign, this is not the only thing that will play a role. The nociceptive sign is the part from the sensory information that is coming from your periphery receptors. But also, visual encoded threat could play a role. Expected threat could play a role. Perceived current status of tissue. Am I okay? Am I an athlete that I was previously injured and now I am seeing another athlete coming to me and I have fear that I'm going to injure myself? How I perceive my current body position. Am I in a good position to avoid this or not? And what is the social threat of this? An athlete or a specific person would react differently in different social situations. And if this situation is perceived from him as a threat, am I going to lose my job because of my low back pain? Or am I an athlete that I am playing in the final game, so I will have minimized my pain in order to be able to play this important game for my career? So all of these are giving you small examples to the multifactorial components that they will define the pain experience of the person. So conceptual models are continuously changing. We were to the pain matrix that defined that pain matrix was like a complex of the sensory part and the emotional part and the reactive and the cognitive part that play a role for the pain experience. And then we know now we are to the pain matrix reloaded, which means that we know now that nociceptive is not a necessity for producing a pain experience. The activation of the pain matrix can also be and take place without a noxious stimuli. You can trigger a pain response by a memory, by a smell, or with other neural nerve roots condition. So this is something that we have to have it in mind specifically if we are dealing with chronic or long-lasting pain patients. And there is also the component of adaptation, or if you want, the maladaptation to the pain. That's why we don't really, if it is in our hands, we try to avoid as long as we can to have a person to be in a pain state for too long, if it's possible. To this paper by Sotiralis Yiannis, we see that pain and pleasure are having the same neurotransmitters in their ways of in their ways of the brain communication. So they did, for example, like an experiment, and you see that if someone is having pain, and you add something add pleasures to the subject, this normally will minimize pain. And the majority of you have observed practically that if you are working with a patient and you are doing with him something which pleases him, then this also adds to minimize the painful experience. If you are doing a painful activity and simultaneously I give you the same amount of pleasure, but I give you M-opioid receptor antagonists, so I am blocking practically your opioids, then the pain remains the same. And this means that this behavior are mediated by opioid. The next example is even more interesting, because if you are in a state that you are feeling okay and you have some amount of pleasure of this, and I give you some pain, then the normal response should be to minimize the effect of the pleasure, which is, I think, logic. But if you are in a state of pleasure, I provoke a little pain, and then I give you opioids, then this leads to a maladaptation of the pain provoked, and this means that you also have pleasure. So if you are in a state of pain for a long time, maybe there is a dysregulation in the opioid reward system, and this also explains a part and a number of the percentage of the patients that they are stuck there in a chronic pain state. Generally, you have to see that motivation plays a role, the context plays a role, anything that could potentially be more important of the threat, it could minimize the pain experience, and it has analgesic effects. Beliefs, culture, and memories matters. Different cultures over the world have different personal approach, emotional approach in the pain experience, and also the reward system plays a role. To summarize all this, how we are going to be sure if there is a need for a paradigm shift, I think that from what we very briefly saw until now, we know that there is a need for a paradigm shift. We have also to be critical, and the only way to do this is by producing research that they will assess the efficacy of the neuroscience approach in the physical therapy or in the medicine compared with the usual care, and to build specific trials that will assess this efficacy. And from what we see that practically we have benefits if we are using this new knowledge about pain mostly, or pain education if you want, or explain pain to our patients, that they were going to be added to our knowledge until now, and we are going to aim to have better results for us and for our patients, of course. Because as you can see, chronic and long-lasting pain is a very, very, very complex cycle that everything matters, and with different percentages in different patients. Some of them are having sensation components more intense. Some of them, their physical activity is mostly reduced. They have kinesiophobia, they have fear avoidance. Some of them, they are having mental problems, they are having depression, they are having other psychological situations that need attention, and emotions plays a role, cognitions plays a role, external factors, family, financial issues play a role to this cycle of chronic pain and the suffering of our patients. I think that it's a good idea to have our minds open to read the literature, the research about this new information that is coming for us, to adapt, to integrate them in our everyday clinical practice. And all of this, it should be for the benefit of our patients and the benefit of our improvement as clinicians. I would like very much to thank you for being even on distance with me, and I hope you enjoyed the presentation. Thank you very much.